And you guide me, Jan, when you feel it'll be a good time to start.
I think you can get started. So I think you can go right ahead. It looks like we have most people on and you can get going.
Perfect. Well, welcome everyone. Thank you so much for joining me. Naftali should be joining shortly, but I'm gonna start. And today the topic is how to work with a pediatric department in the integrated care setting. So hopefully, today's presentation will kind of make your wheel spin of ideas that you can either promote in your site, or if you're already doing it, how to improve them. As usual, feel free to write on the chat if you have any questions, or just unmute yourself and provide any questions or comments or anything like that. We can go to the next slide. Great. So one of the things that I think it's important to always remember is that for those who are in the Department of Mental Health providers supporting the site, the idea that you have to have in your mind is that you're there not just to support patient, but always support your providers too, and also facilitate teamwork. So a big role that as a BHC you're going to be doing in an integrated care setting is that you're going to be assisting and supporting the flow with the PCP, but also the clinic in general. And that's not different if you are in a pediatric setting or just seeing adults. In general, you always have to have in mind that a big part of your role is to improve the work that the PCP is doing, which is gonna actually create that teamwork that we always highlight that it's important. Um, when you are part of a team and you are helping the provider, automatically you're actually supporting the patient and the population of the site, which means that you're going to be able to impactful um, support and help the needs of the clinic. And again, we're going to just today talk about PEDS. So in general, you're going to be penetrating more kids. That's also kind of weird, but I mean like impacting more kids in a way of supporting them. Because a lot of the times what we see is that usually kids will come from the well child checks, and then we dismiss things that can be seen in a preventive way, which will allow us to probably have less cases, in crisis or kind of building up in a mental health, setting. Um, so that takes us to a third point here, which, when you're working as a team, you're allowing that kids will not be falling into the cracks. You're able to identify things that can be seen early and work as on a prevention stage. And I'm going to walk you through some of how exactly this will look like in our next slide. Um, we all talk about the long waiting list. There's a mental health. So when you're working in a setting with a provider, again, you're helping probably tackle things that can be solved in the moment in clinic or in a short version, instead of sending that kid to a waiting list that in some way stigmatized, but also we're kind of affecting the system on the mental health in which is getting back up, and they're just kids there without a lot of intervention for years sometimes. So you just kind of, if you really think about when I put the number from 1 to 6, it's like a domino effect. By helping the provider, you're helping the population you're serving, you're kind of allowing kids to not be falling into the cracks, you're reducing those waiting lists. So one thing start affecting one and to the other. The reduced stigma that we have talked about, but in particularly in PEDS, I think it's very important, not just the reduced stigma of mental health, but for parents. I mean, for parents, it's hard to hear when their kids they're not doing right. So when you're able to work as a team and support them in the side, you're not just reducing the stigma of mental health, but also of parenting, which can be very hard. And I'm going to talk again in that my other slide more about that. Well, and that talks about my last point, which is supporting the parents in general, right? Um, so this slide really represents in very general way what is going to be your role when you're working as a team. So again, you're going to be um, starting with supporting the provider, and that allows to help the patient and allows you to help the system, and also not just the kid, but also the parents and so on. We can go to the next slide. So there's many ways that you can be as a BHC supporting a pediatric site, right? However, what we were trying to do in this slide is just to highlight the areas that are going to be usually more seen, or that we see that it's more impactful. Um, and each of them had different ways in which you as a BHC are very valuable, right? And sometimes it's not seen that way, but then again, on the results, through how you're reducing the burden on the provider and supporting the patient, it's clearly that every PED area needs to work in integration with a BHC. So let's start first with one that lately, due to COVID and screen time and just gadgets, it's super highlight, which is ADHD. And this one is one of my favorites because I think when the providers invite me to evaluate a case for the ADHD, it's interestingly because it's really a big responsibility that either you're gonna start a label for a kiddo, or you can actually be changer in which things can be look very differently. And what I have found out is that once the provider invite us to evaluate a kid that probably has ADHD, based on the protocol that we can use on the clinic, a lot of the times it just relies into changes in the behavioral health life of that patient. Again, we have to think about that some parents come with maybe school are sending them, the teachers are requesting that, but it's important that these type of cases are seen um, in with a lot of quality, I would say, and in depth, because we don't want to just set a label and then put that kid, with that through their lives. So the things that you can support a provider in these stages is definitely facilitating the Vanderbilt screeners, either with the teachers, but also with the parents. I can tell you that I remember in my early stages in clinic when we started to do that, we BHC, it was a small site. We were not a lot, in the clinic. So we were doing everything hands-on. We were actually given the Vanderbilt to the parent. We were contacting the school, allowing the ARLs to be signed and sending that to the school. Things have evolutionated so much in clinic now, and it has grown, and the team has grown so much that now we have a completely different setup. We have someone that supports us on that. So when I describe this, I want you think on your side and see, does this really, will flow well in my clinic flow, or we will need some help? Because what I have heard sometimes is some BHC will say, well, that's a lot. Like, I cannot do that anymore, right? Like, I already have a lot on my plate. But I think it's important to kind of think outside the box and start thinking, how can this look in a clinic flow and how to improve that? So we want to think it's not more work. It's actually, you're going to improve the flow of the clinic. You're going to improve your life as a provider, but also as a mental health, as a BHC, but also your PCP. So when I start describing this, I want you to think about as stages. You can start in a very early stage like I did years ago when I was doing everything, but then things can evolutionate and it can be like a clinic system. So again, you can facilitate the Vanderbilt clinic flow, either you doing it or setting a system in your clinic that will work. Follow up with the schools, medication adherence, if that kid is already diagnosed with ADHD and how that's working, or if you're going to start just the medication and supporting the provider with that decision. And the behavioral strategies. That's very important because we find out that a lot of the times these are kids that they don't have structure, or their eating habits are different. And one of the things I like to explain to providers, but also to the parents, is that this is like a different, like a puzzle you're gonna complete. So one piece of the puzzle will be, the behavioral strategies. The other piece of the puzzle will be medication. The other piece of the puzzle is a collaboration with the teachers, like all has to come in place. And if you're not there to kind of coordinate that, can feel very isolated, and then can be a kid that can, be fall into the cracks, in which is a kid who got a label, medication, and who knows what structure they have in the house, what behavioral strategies need to be in place, if he's improving or not in school. So because there's a lot of components of this diagnosis, it's important that you facilitate that kind of flow, bringing everyone together to work as a team with school providers and also the family. So that's an area that you can impact as a BHC working in a PEDS environment. Now, when I talk about systems, I think Natalie, were you going to say something?
Sorry, like, I was. Yeah, no, I was just going to add to that explanation, just emphasize the flow thing. So with ADHD screening in particular, I definitely recommend, if you can, automate the school process, because that's the process that takes the most time and is a rate limiting step for you. So when you want to get information back from the school, if you're just handing a form to a parent, you're going to get about a 20% return rate on that form if they're having to hand it to the teacher to fill out. And or the other thing that we try to do in pediatrics a lot is try to be very timely in our care provision. It can delay care. So let's say you see, for example, a kid that you see, let's say in the middle of September. So early on in the school year, teachers having some concerns, talks to the parent brings them into the clinic, and then you have this integrated service and you say, well, okay, all we can do today is just do an assessment, and you give them the Vanderbilts. 2 weeks later, you ask them to come back. That's 2 weeks already that have gone by. They come back, but they don't have the teacher form. So all you have is the parents form, which is the same information you had, by the way, at the first visit, right? So you just lost 2 weeks, and then maybe you try to call, maybe you try to get that form back later on. The point is, you can then have a child who is struggling in school, who could have benefited from medication early on, for example, potentially 2-3 months into a school year, with a lot of consequences for that child as far as grades and all that. So one of the concepts in pediatrics is think about timeliness of your care and developing flows and processes that get you to the place where you're actually providing help sooner rather than later. Too many places, I think, especially with ADHD, take too conservative of an approach and just delay care, because of what Martha said. You don't want to label a kid, you don't want to stigmatize the child and all that, but the opposite is you can delay care so much that child can continue to struggle and have really serious consequences in school, when it may just be helpful to do a trial on a medication, given enough information to move forward. So think about the timeliness of care, and then just also the flow. If you can automate, so one of the things that we did at the clinic that Martha was, is just automate it. So we're able to send an email to the teachers, they can click a link, and boom, we would have those Vanderbilts back within 24 hours.
Yep. Thank you for sharing that. I was actually going to share that process of the electronic way that you can do it. So definitely those are things that you can explore. Go back to, and then we go next to another topic that is very common, which is parenting. And like I mentioned early, parenting can be very, feeling very judged, right? When a parent goes and brings their kid to their medical doctor, and then the parent hears the news that things are not well with that child, it automatically puts kind of that guilt on the parent of what I'm doing wrong, how can I improve things? And a lot of the times your role there is actually to balance that parenting is hard, and kind of to allow that parent to have a vulnerable place to talk about what they're feeling, what's happening with the child, but helps them move forward. So a lot of the things that we find out doing as a BHC is just even the very basic, like behavioral charts explaining how timeouts work, consistency, that it gets worse before it gets better. So things that maybe as a provider for you seem very, like it's common sense. 80% of the times I find out that for parents it's not, right? So because when they start implementing a behavioral change and things get actually worse, that's when they feel like I cannot do this anymore. But if they hear that actually that's the way it goes when you're creating a change of behavior, it can make a big difference. So your role there, it's a lot too of doing psychoeducation, normalizing, and you're bringing tools that the parent can use so they can support that, a change of behavior they want to create on the kids. So that's kind of, again, going back to, if we're talking about, night routines, bedwetting, or eating habits, just the very general things that some parents can struggle. And then, also we hear, well, I have my kid one, but it didn't act like my kid too, and just kind of normalizing that kids are different. You're not failing as a parent. It's just you have to manage things differently with each kid, and allowing the parent to have that space of support with you. That when you think about it, when they come and see the provider does not have the time, or maybe, I would say the time to go in specific with these things, right? They have to go and kind of check some boxes. So your participation is going to be very helpful, again, not just for the parent and the kid, but the provider. There's been many times in which, when as a provider invite me to go and evaluate a kid, I am able to find a big reason of what's going on that the provider was not able to realize that in the regular questions, right? If like there's stress in the family, or any important things that are happening. And that's very valuable information that you're bringing to the provider, so that you both as a team can see the case differently and being able to support the family. If we go, go ahead. Go.
Just to allow you a chance to sip your water. So a key sort of cross-cutting theme you'll see here is that most of the work that we do in pediatrics is with the parent. So our main interventions are typically with parents. So we're not doing like child therapy, by and large, or play therapy, things like that in a primary care setting. We're mostly working through the parents to impact their children. Now, the exception, and Martha will get into this, would be potentially with adolescents, potentially with like the eating disorders, or even just adolescents in general, who are at a certain place where the nature of the issue and their level of development means that we would maybe sit with them in the exam room and work with them semi-independently. But most of the time, even in those situations, we're really trying hard to be inclusive of the child's context, because those are the adults that have significant sway and power in that child's life. So we're always trying to integrate the parents into what we're doing. But that's an important distinction, because some folks who do come from a certain way of working with kids think of working with kids as like directly interacting with the kid and directing the interventions there. And in primary care, 90% of it is going to be through the parents.
I'm so glad you're highlighting that, Love, because it's common that people can get confused about the type of role they're doing in the clinic, and even also will bounce back to, I have heard, what billing code should I use with a kid? That there's no different codes. I mean, for a kid, it's just the regular psychotherapy code, which can be usually a 30-minute, unless it was a safety concern and you go over that. But there's no difference either also with, the billing. And another important thing to highlight is that also, as a provider, you have to know when there's the need that there's a kid that needs more specialty care, right? And you can still bridge that, seeing the kid and supporting the parent, but not necessarily jumping into play therapy and all those type of things. So this is exactly viewed the same way if you're seeing an adult in which you realize this is an adult that needs more specialty care. I will bridge that care, but then communicate, like you communicate to the patient, in this case, communicate to the parent. It will be helpful if the kid is being seen in a different setting. So that rule continues to be there. There's no distinction or difference between being in peds or adults.
And I want to emphasize also the point you made already, that if you look at each of these issues, you are designing an integrated care program that's offloading work that your providers are already being asked to do, right? So when you think about each of these columns, your pediatric providers are already trying their best to support patients with these issues. So you're not really tagging on something extra, but you are bringing a professional who has oftentimes better capability and certainly more time to work with these issues. And that's an important thing just to keep in mind. Your pediatricians are already being asked to handle all these issues on top of everything else they have to handle with the care of their patients. And so it is a really big help when you add a member to the team that can do that basic behavioral chart, timeout education, the psychoeducation around what's normal for the development of that child's age, behavior-wise, any other parent-child interaction issues. It's pediatricians, once they really get this, they love it because it frees them up to really spend quality time with their patients on other things.
Oh, I think there you go. Good. So then if we go to the third column of behavioral issues and we go down to the things that they're describing here, it's very similar to what I mentioned about parenting, but a little bit more specific based on whatever the behavioral issue it is, right? So you're going to help the parent create routines at home, probably, share behavioral charts, definitely providing that psychoeducation based on whatever behavioral issue they are dealing with, and just that support, that encouragement to the parent. One of the things I find out with very early professional behavioral health consultants is they feel intimidated when they're not parents to deal with pediatric issues. And one of the things I like to highlight when we're training them is that they really think about, for example, I let them know, I said, well, do you, when you see an adult, do you have or are struggling, for example, with an eating disorder? Do you personally? And then they replied to me, no. Are you able to help that adult with that eating disorder and functioning better? And they said, yes. I said, it's exactly the same. You're going to think about this. You're just going to help the parent and the child to function better, to do their daily life more efficient and with less problems what they're dealing. But don't feel intimidated if you haven't been a parent. It's just going to see these exactly the same as you're seeing an adult. And that kind of just brings a little bit of peace on them, because they said, well, but the parent knows better because they know the kid. I said, yes, but remember, you're coming from a perspective of how I can help this child and this parent function better between them in the relationship and in their day. And that's very easy to do when you're seeing the problem from the outside setting and knowing, for example, the parent is feeling guilty and is not consistent on what they're doing, right? Or it seems like the kid is just having temper tantrums because there's not really a routine in the sleeping. So that's easy for you to see from the outside and still provide that support. If we go to the fourth column with eating disorders, one of the things that I discover is that we really have to take into consideration, and that's why I put it here in the first slot, the cultural adaptations. When we are seeing a patient that comes from a minority group, a lot of the times they already, for example, they talk to the PCP and they got referred probably to a dietitian to give them some recommendations in their site. But then we find out that the recommendations that were provided had nothing to do with what they usually have in their house or they use culturally in their house. And then there's a mismatch there. So even those little tiny things as to what are the recommendations of the calorie intake and foods that patient is receiving, you as a BHC can be very sensitive to even cultural components that can be missing. And that can be a really important shift point, either in the relationship of the patient with the clinic in general, but also to support that family in what they're dealing. And well, I can tell you, because I work a lot with the Latinx community, we have particularly have been females that they're struggling with this, but then the recommendations given, they don't make sense with usually what they're used at home and their cultural beliefs. But not just in foods, but also how they perceive the disorder, right? So it's very common that parents will say, oh, she's a bracket, doesn't want to eat, and it's hard for them to understand that this is actually a mental health disorder. And you bring that, you are bringing there to kind of explain them that this is look different, but it can look, the eating disorder can be look so different, and any mental health struggles. But in particular, this one I find out that culturally can mean very different for the kids and for the parents, and actually how the provider is seeing it as well. So you're playing a very important role to kind of educate the parent in the issue and how they can support the kid, in particularly also with the culture they're experiencing in the United States. If they are not, if the kid is acculturated, but the parents are not, it can look very different. So that's why I like to highlight it over there. And then again, you help with the routines and making sure safety, how they can keep their kids safety when, again, from the parent side, there's a conception of, they just are angry at me and they're doing this on purpose, and just educating that this can look very different. In these cases, again, like Naftali was mentioning, yes, there's a lot of working with the teen along, but we always want to pair and bring the parent or that support person that it's near that child.
Yeah, and I would say that this is a good example of something that oftentimes when people think of integrated care, they think, oh, we can't treat eating disorders in primary care. That's something we have to refer out. And that's not what Martha is describing. That's not necessarily the case. In fact, it's not necessarily the most helpful thing. It is often very helpful to be able to meet the usually adolescent with their pediatrician, because they're coming back to see their pediatrician potentially for some of the nutritional deficits they're experiencing, some of the tooth decay that they may be experiencing as part of their disorder, or any other sorts of issues related to their eating disorder. And they would never go, or the parent, like Martha said, the parent may not really identify it as a mental health issue. So why would they bring their daughter to a mental health professional, right? But they will bring the child to the pediatrician. And then the other piece is that there are really helpful things that you can accomplish in primary care to support patients with an eating disorder, as Martha has outlined. So it's important to adopt that PCBH mentality of there's always something I can do to help this patient in this situation, or this family in this situation. And a lot of it just goes back to a couple of things to highlight, which have a lot to do with pediatrics. So one is just, we have a very strength-based approach with families and with parents in particular. So we fundamentally believe that the parents have what it takes to solve these issues, to work on these issues collaboratively with their adolescent. And so we are going to aim to coach them. Some of that's education. Some of that's coming up with potentially behavior plans that help the affected kids feel more in control of their eating behaviors, and help the parents potentially lay off of their kids, right? If they're pressuring them to eat, for example, if anorexia or restriction is an issue, or if they're stigmatizing or making their child feel bad when they purge, right? Something as simple as helping calm a parent down and say, yes, I know this really feels bad for you, but the best thing we can do here is not to shame your child when you find out that they purged, right? So small things like that make huge differences in the alliance between the parent and the child, so that they can start working together and use that strength that we believe is there to continue to solve the challenges of working or of living with an eating disorder. So just a mindset shift that we really do mean it when we say we want to keep 85 and 90% of what we see in-house, and only refer out that 10, 15% that we really feel is going to need more specialty care. And even then, like Martha said, we still will meet with them when they come see their pediatrician to check in, to bridge care if there's a lapse in care with their specialty provider, et cetera.
one of the things that I have found out is that even when I have made the decision of saying, I think this is someone that will need more specialty care, and I start bridging that service, I'll surprise myself as well that when I'm bridging that service, at the time while I was bridging the service, they don't need the specialty care anymore. Their improvement got so much that even though in the beginning I thought, well, this needs more specialty care, while I'm bridging the service, things got solved got better, and they don't need to be placed on the waiting list anymore. So those have been even learning experiences for me, right, as well, because let's face it, I mean, the reality of the life of people changes, and it not always changed for the bad. There's also change for the good.
That's a great point, Martha, because that's especially true in pediatrics. Like, kids change very quickly. So you can go from one, like a semester, I always think of school semesters for kids, and they're really struggling, and then something switches and, you know, they're in a different place. You know, or they just, I've worked with adolescents where because you're in primary care and pediatrics, you actually can see adolescents for years, right? Through their teen years. So I've seen some teens through their high school years. And, you know, you start out seeing them as a sophomore for a few visits that year, and then you see them senior year, and they're not struggling with the same things anymore. And like you said, they didn't have potentially access to specialty mental health. They made it through with the coaching our team was able to provide. So that is a very good point, Martha. That you know, you sometimes will surprise yourself about who actually benefits from primary care versus specialty care.
We're now in the fifth column, which is the learning issues, and it's going to be very similar to what we do in all of them. It's just a different angle or focus you're going to be taking, but it comes again to that psychoeducation to the parent, sometimes to the kids as well. If there's the need to make that referral, so facilitating that flow, right? Let's again remind that for parents, this can be probably the first time they're listening to a learning disability. They don't know what to do, they need to advocate in their school system even. So just by coaching them on that is helpful, how to have that advocacy for their child, either in their school or wherever you're gonna refer them. And going back to, as we started in the ADHD, the communication with the school. What I have found sometimes is that there's a mix match of what the parent is saying to the provider and what the school is saying. So there's a lack of communication there. So sometimes that's helpful to be clarified, and you can be very helpful in that process, in which the parent is sensing, I don't think there's a learning disability or a learning issue. School is saying yes, and just putting, kind of helping that communication and that flow can be very helpful. And that helps the provider know, okay, what do we need to do here? They're trying their best with what they have, but a lot of the times they don't have the complete story. They don't have the complete issue that is happening, and you come to kind of complete that and then make things easier for the family, the student, and of course the provider, and even the school. And lastly, yeah, go ahead.
Before we move on to the last piece, I think the point I raised before about timeliness is really important here. And probably this is a personal passion of mine, but education is one of the biggest components of a child's sort of early development, their well-being, and their sort of lifelong achievement. And so the more we delay the processes that need to be in place for a child to succeed, the more failure we bring to that child's life, the worse the outcomes, essentially. So speed, time to treatment, is one of those concepts that we talk a lot about in PCBH work. That also applies to learning issues, even though in PCBH work, we're not doing like full assessments for learning disabilities, typically in primary care. But we can advocate by ruling things out and then writing a letter, right? So like, let's say we do an assessment and, we don't think it's ADHD. we've assessed the parents, and we don't think it's environmental. We don't think there's any sort of impact of trauma. Documenting all those pieces, it can be an important way for the parent then to go to school and advocate for an IEP or for an evaluation for a formal learning issue. So, just taking the extra time to document clearly in a letter your concerns on behalf of the care team, what you've ruled out and what you recommend, and then have the parent go to the school with that letter can be a way of speeding up the process and getting the school to then get down to business and make sure that they do the psychoeducational testing that's needed. As an aside, when I worked in Chicago, I worked on the west side of Chicago, that school system was so bad that I actually did start doing psychoeducational assessments, like mini batteries that I could complete in about half hour to 45 minutes. And I did that because the school systems would not move learning disability issues, and they were sending kids to us in pediatrics to be put on medication who honestly they didn't need medication, they just had learning delays. And in order to advocate, we would do these mini batteries of KBITs and KTs in clinic, and then write a brief letter saying, here's what we found, we're ruling this out. You must evaluate this child formally for a learning delay. So in some school systems, and you have to match what your patients need, you may need to do a little bit more advocacy there from the primary care side of things in order to spur those and make sure that kids don't get delayed, especially at the younger ages, obviously.
When you were sharing that story, it just brought to my mind that there have been multiple cases in which when I asked the parent, and I'm assuming, I'm thinking that there's a learning issue that I'm encountering with that particular patient, and I asked the parent if they have advocated for an EIP, they don't even know what an EIP it is, right? Again, talking about people who come from other countries, this is a different system. So from them, it's completely like, I don't know, what is it? So even just educating them that there's this program that they can implement, the school implements, and that how that will work and how they will work together with the school. So like you mentioned, even just those little tiny pieces of education to the parent can be life-changing for that particular case.
Yeah, and you actually brought up another sort of tangential story where oftentimes when you have kids with kind of a combination of either ADHD or learning issues or both, you often also have what we kind of term like occupational therapy type needs, right? So they maybe have some sensory issues, for example, like sensory integration issues. And so in that case, your role also is to begin to advocate within the health system, because a lot of times the pediatrician will not pick up on that. They'll just pick up on the ADHD issues and be working with medication, the learning issues in school, but no one has picked up that sort of a central issue with the child is sensory integration issues. And occupational therapy can be very good for that, especially for younger kids. So I have been in a place where I will make that note to the pediatrician, say, hey, have you considered OT for this child? And that, again, is a way of advocating within the health system so that the child gets the services that they need as early and as quickly as possible.
Great. And then lastly, we have, the mental health part, in which, again, part of the responsibility as a BHC is just making sure, assess well what's going on with the patient, with the screeners, checking for safety, but bringing that part of education to the parent as well, what they can do. So just imagine a parent who is in clinic because find out that the kid is depressed and it's, hurting themselves or with thoughts of ideas. How scary it would be as a parent, go home with this kid and knowing that, they might do something that will really affect their lives. So just to kind of be able to set up a plan with the parent can be very validating for them, because they're gonna, at the end of the day, go, out of clinic with their child and that can be very scary. So that's a big component that you can support the parent, not just educate them on the mental health part, but creating a safety plan and letting them know what they can do. With adolescents, we also find that our role is educating if that adolescent is going to start a medication, how this medication needs to be addressed, what things to look like as a parent if symptoms get worse, starting in a young age SSRI, the way they need to kind of monitor that medication with the child. So those are very important components that you play that role with the family, I would say. And then again, going back to if this is someone who needs specialty care, I have had times in which the provider, and I think, I don't know if I shared this story with this group, but I received a warm handoff, and it was a provider who told me that it was an adolescent who was very anxious, and the mother was very concerned, and they really wanted, the traditional mental health service. When I went into the room, the reason that the teen was anxious, it was because he just had found out that he was undocumented and was not going to be able to continue his college studies. That was the real cause of their anxiety and kind of that depression. A very brilliant student, straight A's, but it was just a wake-up moment because he didn't know that. The solution that session, and I really like this case because it was one of made my day, it was basically to inform and educate the parent that there was a school system with a community college here in town, that they have a program that they will accept these kids and even support them financially to continue their first 2 years of college in a community college, without no questions asked about their social security or their immigration status. And this was just life-changing for this kid. If I hadn't come and assessed that, this kid will probably have gone into a waiting list with anxiety and depression. And because I was able to come in and assess what was the cause of the session, it was a solution right there. Timely wise, there was going to be an induction of that program that it was funded that Saturday. So I gave them actually the name and the date and the time of where they needed to be in order to enroll the kid. That was life changing for the family. They went, and then I kind of scheduled them just to follow up, and the kid was happy and enrolled and continued, their dream to continue the education. So this is an example of one. Sometimes you can get a warm hand of thinking this is how I'm gonna find the room, and then you go and it's completely something different. And again, this is a story in which there was someone that they does not needed to be in a waiting list. The solution was very different, and it was about educating a parent of a community service that was there that they can use that they didn't know. So again, as you can see with all this, the power that you bring to a session with not just the patient, but empowering the provider as well, like Neftali shared the story of the sensory needs for the kid, it's tremendous. So I hope all this description helps you kind of think about how I can make the life of the provider better, of patients and the site that I work, and can inspire you that there's a reason why integration needs to be there, and how it helps in general the system, not just the health system, but the mental health system as well.
And I would just also say, and maybe this is a question for you too, Martha, just, on first glance, working with kids can feel a little bit intimidating. You addressed that earlier around, the BHCs that are sometimes shy about giving parents advice, right? You talked about that example. But if you look at the different array of issues and situations that you've put out here, it can feel intimidating, but it's important to understand that, and the boxes kind of help in a way to show that the skills overlap. In other words, you don't have to be like an eating disorder specialist to help someone with eating disorders, right? As a mental health professional, you don't have to be an expert in ADHD to help in these areas. What happens in primary care, typically for mental health professionals that you may hire, is that they will learn as they go. You pick up competencies and you become more adept in each of these areas. And to be clear about that, that's also true of medical providers. Like a pediatrician straight out of residency is not perfectly adept at handling these sorts of issues. They will gain experience as they go. Hopefully they have an environment that allows them to learn and be mentored by other folks. And that's what we definitely recommend for behavioral health consultants working in these environments, that they have some mentoring, some support around pediatrics specifically, because there is a good deal of information to kind of absorb and understand. But the actual skills and tools you end up using in the end are quite similar. Because you're almost always working with the parents. And so those skills that you work with parents across issues are going to look alike. You're going to be thinking very functionally. So you're going to be looking at behavior in context, whether it's an eating disorder or depression. And you're going to be supporting the pediatrician in very similar ways by helping with psychoeducation, helping guide treatment and care, and connecting the work in the clinic to what's going on in school, for example, or in the home effectively. So all those things are going to cross over these issues and make it feel like less daunting than it might look like on paper here.
But if we can go to the next slide. Now, with this slide, what we want to reflect is that I started early saying how sometimes also you will help that flow of the clinic, right? It should not feel like it's going to be something else to do, but instead facilitate the flow and avoid that kids will get dropped on, between the cracks. So we did an example here of what it will look like to kind of implement the COCM in pediatrics. And we have talked about COCM before, so I'm not going to spend time talking about it. But really, really quick, it's you create a database of patients and you're going to track them and make sure that, kind of see if those symptoms are improved. So we think about making a list of kids who had ADHD. What would happen or how it will look like is that you're going to have that database of those patients. And then you want to make sure that you're going to do a systemized flow with them. So everyone, in this case, I put in the second step, they should have the Vanderbilt results from parents and the teachers. So you should have that in your database, those results. And then how you're going to follow up with those patients, in this case, with those parents, or even school as well. If every, if they start medication or not, that has to be marked. When you're going to make a follow-up call or visit if they come into the clinic, with the idea that you want to keep that data with the intention to how things are developed for that particular patient, tracking the improvement of symptoms. And the thing that happens with this is that at the end, of course, you're helping the patient to improve, but you're allowing some of those cases to not fall into the cracks. Because what happens is the parent comes, they get a diagnosed with ADHD, for example. And sorry, there's a typo there. I put ADHD. And then you don't see them again, right? Or this was diagnosed probably at the end of the school year, and then you don't see them through the summer at all. And then in September, everybody having PEDS referrals, right? So this allows to help the flow of the clinic to avoid patients to fall into the cracks, but also to keep monitoring how things are evolving. Because it's usually, this type of list, what happens is that then you're on top of things, avoiding those type of patients who then are going to come failing the grade, or like what the issue that Naftali was mentioning about the timing, that important step of the timing, to keep track how things are going for that patient. So this kind of shows an example of that. You can also do it for kids who probably are struggling with depression or anxiety, right? So, or one of the other lists that we do in clinic, it's for those who don't follow up with their yearly checkups. Like there's kids that they don't ever come, but we started creating this list, and the system was highlighting to us those, and then also always including BHC in those yearly checkups as a routine, as a part of just as part of the vaccinations they need to have yearly, at least one BHC visit. And then there was a system that was created to create that flow, and it was helpful because we were ahead of having those problems that probably later will come if a patient is not seen.
Yeah, a typical scenario for this also is just the kid who gets diagnosed with ADHD or has a historical diagnosis, gets put on medication, but then has a certain number of refills and then doesn't come in time to get their next refill of the medication, and then calls the provider and says, or sends a message to the provider and says, oh, I need a refill on my medication, but they haven't been seen in 4 or 5 months. And the provider then is in a pickle. It's like, do I refill the medication or do I ask them to come back in? Because if I ask them to come back in, it might be a few weeks before they can actually come in to see me, right? So this system that Martha's outlined would help catch those patients earlier on, track care so that the provider could actually turn to the BHC and say, hey, or actually they could probably see it in the EHR notes, but they could say, hey, I've got this patient asking for a refill. What do you recommend? And sometimes we might say, yeah, they need to come in because they really have not been responsive, and we're not sure whether this is the right medication for them to be on, et cetera. Or you might say, no, you know what, we've followed up with them. They're on pace. They've really benefited from medication. A refill makes sense. So it's just an example, a very practical example of how when you have these lists and folks managing these lists, it can be really, really helpful. The other piece here that Martha didn't outline specifically, but is in the background of this, is also consulting psychiatry. So, in those cases where you do have, they're pretty rare in pediatrics, but where you do have some concerns medication-wise, either because the child has failed sort of all the available or normally known types of medications for ADHD, then the consulting psychiatrist can weigh in on it and say, try this or this, this is what I recommend, et cetera. Or for a medically complex child, which again is more rare, check for medication interactions. So that's another benefit of having a database that you can review and make sure that some of those more complicated situations are attended to effectively.
And also, I think this type of database will help you to collect data, which we have this, talk before, how data is important when you want to make your point across as why it's important to have integration or the benefit that will bring to a particular population, or to set a new goal, and you want to bring this information to leadership to make a point. So that's also important things behind, collecting that data. So with this, we have 6 minutes for comments, questions. And remind you that some of you are already using the time as having one-on-one sessions with us for consultation. Just a reminder that that's something that you can use through WCHQ. If that's the case, just email me and we will book that with you guys. But I'm going to open it if anyone has questions, comments.
I hope you can tell that Martha and I love working with kids. It's really fun and very rewarding. It's difficult sometimes because it's more people in an exam room, so it hurts the brain sometimes. There's a lot of issues at play, but it's one of the most rewarding kinds of interactions we have in primary care for sure. Wow, I think we might have answered all their questions.
Jen, usually you have some of announcements or whatever. Yeah. I don't know if you have.
Just brief follow-up that this Thursday is our disparities. Tomorrow is our big disparity summit in Brookfield. If you have not signed up for it, you could probably still sign up to attend virtually. We will have another one next year, but I just wanted to announce that. And then after this meeting, sometime next week, I will send Martha's slides along with the survey and other information. So thanks everybody for being here. And again, as Martha said, a lot of groups have been using the one-to-one consultation and really enjoying that for very basic things or for very complex things. And if you want to use that consultation, just reach out to Martha or myself and we will get you set up to do that. So thanks everybody.
Have a great week, everyone.
Thank you, Martha.
Great training.
Thank you. Thank you, Naftali.